All right, I think I'll get started with an introduction just of the U24 agenda and summer meeting, and then we'll launch into Dr. Barb's talk. Welcome, everyone. Thank you for joining us. We wanted to take a moment to, sorry, I'm Laura Case, one of the co-Is on the U24, and I'll be co-hosting this virtual seminar with Dr. Victoria Abrera, also on the call here, and it will be recorded for later dissemination. So I wanted to take a moment and just let everyone know, if you haven't heard already, that we are hosting an inaugural conference on mechanisms of touch and force-based manipulations this summer. This is going to be a joint effort of Neurons Matter, ForceNet, and SpineWorks, the three U24 networks that are sponsored by NCCIH and NINDS. It will be August 6th to 7th of this summer at the University of Virginia, Northern Virginia campus in Fairfax, Virginia. So we want to invite everyone to apply. I think registration opens April 1st, and we will have travel awards available for trainees and early career folks as well. We'll have keynotes, presentations, poster sessions, exhibitors, and some NIH representatives there, hoping to turn this into an annual event. So reach out if you have any questions about that. And then I am delighted that we have Dr. Mary Barbe, PhD and fellow of the American Association for Anatomy here with us today. She is also a co-I on the Neurons Matter U24 grant. Dr. Barbe is a classically trained anatomist with expertise in neurobiology and neuroscience of musculoskeletal biology. She has 35 years of experience examining various aspects of peripheral and central neuroplasticity, ranging from changes occurring in the bladder, spinal cord, and brain after injury or gene knockout. She's currently exploring inducers of tissue fibrosis and degeneration occurring with overuse and effective interventions. She has over 230 peer-reviewed publications and is funded by the NIH and Department of Defense. And she also serves on the Cure Advisor Committee. So Dr. Barbe is going to speak with us today, and I know that she's planning to create a review paper out of some of this material. She can tell us more. And so she's very eager for your feedback and thoughts on the mechanisms that she will be discussing today. Thank you, Dr. Barbe.
Thank you. Thank you for the invitation. So let me see. Share.
Feel free to type questions into the chat, or we'll take questions at the end as well.
Okay. All right. You see my screen. And then let me take off the floating. So I'm going to have a message from Zoom. Okay. Excellent. So today I'm going to talk about some findings. Wait a minute. Some findings that I've discovered in an animal model where I use manual therapy treatments for treatment of repetitive strain injuries. And what I found in general in this model, not just with the manual therapy, is that prevention is easy while reversal is difficult. I would like to thank Jeff Bove, who was the key person participating in the manual therapy advice, how to develop it, how to apply it, how to utilize it. And then Ann Barr and Brian Clark, who helped me develop the model ever so many years ago. I have no conflicts of interest. I should start with what is the model. I study repetitive overuse injury. It's also called repetitive strain injury, RSIs, work-related musculoskeletal disorders. It could with the different definitions there, overuse induced musculoskeletal disorders. And the use of musculoskeletal disorder does not say that nerves are not involved. Nerves are very much involved, as you'll see. Some of the symptoms include pain, discomfort, and motor weakness. Diagnoses are many for upper extremity. work-related musculoskeletal disorders, which is what I focus on. They include tendinitis, tendinosis, myalgia, which is like a muscle inflammation, lateral epicondylitis, carpal tunnel syndrome, pipette man syndrome, computer mouth syndrome, etc. I have also studied other types of work-related musculoskeletal disorders, and they include low back pain. But today I'll be focusing on upper extremity. There are multiple risk factors, including doing a task at high repetition, high force, prolonged times in these, awkward positions. Um, and as you'll see in a minute, the animal has their arm all the way extended, advancing age. I won't be presenting that today, but we have studied that. There's also a predominance of these disorders in people of female gender, and then vibration disorders, like the truck drivers who have their hands constantly on the stick shift of in their big trucks going on roads, for example, with a lot of vibration. The etiology by the Occupational Safety and Health Association defines these disorders as in wide tissue variance throughout the upper extremity. Muscles, tendons, ligaments, joint, cartilage, blood vessels, nerves, spinal disc, all of this that have been associated with the exposure to risk factors, those risk factors being the ones we just named down here below. This exposure is typically repeated. So it's cumulative trauma. And there's insufficient rest time between exposures to heal properly. So one treatment that some people use is extending the rest time, for example. Over the long term, though, with cumulative traumas, a relatively innocuous task becomes difficult or impossible to perform for the person with these problems, including like buttoning their shirts and getting dressed or even sleeping because of the pain that they've developed. So in 1998, I set out to develop an operant rat model of upper extremity overuse to examine tissues for underlying mechanisms contributing to behavioral functional declines like injury, inflammation, fibrosis, and degradation. In addition to identifying these underlying mechanisms, I've sought to also look for effective interventions. Here's the rat model. You can see that it begins with a rat in an operant chamber, and they're investigating a portal. They've learned to reach through the portal. Now they've been trained to reach and pull a lever bar on the other side of the portal. You can see here from a bird's eye view. This is a force transducer. And if they do it in the right time frame, to the right force, they get a food reward. Now, before I show the movie, the training takes like 5 to 6 weeks to reach at high force levels. And they have to ramp up from naive to the high force level. It's 15 minutes a day, 5 days a week. There is a negative training effect, particularly in the last weeks, they're doing the high force itself. Because it's a fatigue failure sort of concept that once you pull, as you can see below here, at 48% of your maximum pulling force, even for this short period of time, you can actually create small injuries in the tissue that are then the premise of the cumulative trauma. Once they learn this task, let me like show the task, and then we'll talk about what they're doing. So a light just went off saying, yay, you reached the right time frame.
She's had a partial pulse.
They can get partial pulls or full pulls. They're waiting. The clicker tells them to go. The light goes off and says, I did it. I reached in the right time frame, pulled to the right force, and I got a food with it. The food reward is a mixture now of chocolate and um, banana yogurt flavors treats, which I work for too, so I get it. Um, particular work I'm presenting today is a high repetition, high force, although we have changed this through the years and done different paradigms. In this one, they're reaching and pulling that lever bar for 3 to 12 weeks, depending on the study. The target is 4 reaches a minute, but they tend to over pull in their excitement to get that food reward. Um, it's 48% of their maximum pulling force. I had to lower it. I initially started with up to 60, but the animals have a hard time pulling very long past 40% of their maximum pulling force, which is 1.27 newtons. And then this is a union job. So they're doing 2 hours a day and 4 30-minute sessions, 3 days a week. And that's a picture of Ann Barr. For the model, yes, we get like a carpal tunnel syndrome and muscle myalgia. The animals develop a peripheral sensitization where we're doing a 4-paw limb withdrawal test of Von Fry here, where the animals, this is their normal responses to different size filaments in the control animals. And then as they develop the overuse injury, there's a shift to the left, which is a peripheral sensitization, an allodynia, and was shift to the left. So they're now responding to filaments they don't normally respond to. There's also a development of myalgia, and discomfort in the muscle itself. And for this, we use a grip strength meter, and we gently pull on the animal's base of their tail until their grip is broken from this lever bar that you see here. And that is the moment where it's the discomfort. And you could see that the grip and the controls stays pretty steady over time, while in these animals that did an 18-week high repetition, high force task, there's a progressive decline in their ability to perform this task. In studies with Brian Clark, we were doing electrophysiology, because electrophysiology is like the key point of what one looks for the person with carpal tunnel syndrome. So we were looking in the median nerve, and this was an open test of the median nerve conduction velocity at that time. And what we saw looking through the microscope and a normal median nerve at the level of the wrist, that it's like nice, clean, nerve going through the carpal tunnel. But in animals that did this task, we saw repeatedly this development of a connective tissue nodule around the nerve, which impedes function. And if you look at the nerve conduction velocity, which was done during this time, the animals, the 9 to 12-week limbs of animals that did the task, have a slowing of their conduction velocity compared to animals that were 0-week. When we section that tissue and look under the microscope for proteins, the connective tissue growth factor, also called CCN2, cell communication network 2, or collagen, what we see is all this extraneural fibrosis, matching what we saw visually in the microscope as this connective tissue nodule. And that was impeding the conduction velocity and slowing it down, just like it would in humans with this disorder. And when we quantify the extraneural fibrosis, we see the percent of dense collagen has increased. You see a similar increase. The collagen is in green here. Here are the controls. This is the high repetition, high force animals. You see an increase in green in and outside the muscle fibers of the task animals, as well as connective tissue growth factor, which is an extracellular matrix molecule that's actually driving more collagen. And here's an injury site in the muscle itself. And then you see the same sort of buildup of bands of fibrous tissue in the extracellular matrix of the forepaw, very similar to a Dupuytren's contracture development of collagen. And there's the nerve there. And so there's a general sort of increase in collagen and extracellular matrix. So my first theory was a fibrotic container hypothesis, suggesting that excessive fibrosis acts as a self-propagating container, which is what the hypothesis is online. It's seen also in like pulmonary fibrosis, for example, that actually can drive disease progression by creating a dysfunctional, rigid environment. It's a lot of collagen, extracellular matrix components, and it creates a positive feedback loop that leads to chronic inflammation, tissue stiffening, and organ dysfunction. In this case, it's like it's compressing the nerves and the muscle tissues and even tendons. I'm not going to show a lot of that data today. That's utilized for the lever pulling, and therefore is reducing the functional attributes of this lever pulling. So our big question with Jeff Bove was, will a conservative treatment like model manual therapy be an effective treatment, perhaps in breaking the collagen adhesions itself? So our first experiment was to have animals that rested, animals that did the high repetition, high force as a positive control without treatment. So these are the positive controls without treatment versus animals that received the model manual therapy. And they got it 10 minutes a day, 5 days a week throughout the work period for the whole 12 weeks of the task. And then we did our tissue and serum analysis. This is the therapy. So we'll have skin rolling, mobilization, a myofascial release, a joint mobilization, and a passive stretch. And this is
So
just
this is the mobilization, muscle mobilization, and my middle finger is moving that flexor wad back and forth.
you can see the animal tolerate
This
it
is
pretty well.
I'm stabilizing with my thumb and forefinger and holding it, the distal humerus here, and pushing the skin up to the wrist and dragging back. 2, 3. So I'm not pushing there. It's push and then a passive return. So it's just a slide and then push, slide, push, slide, push, slide, push, slide, push, slide, push, push.
And this was included because we saw that muscle tendon fibrosis and the extracellular matrix fibrosis. So we were trying to address that in the treatment.
Then find her little wrist and do P to A with a little traction.
And this is for the carpal tunnel release.
And then do some rotatory axial rotation. And I forgot that because I've done this now 10 times. So I've forgotten that we were going to do take all the skin and kind of pinch it, pinch it and kind of roll it a little bit in between your fingertips. Just make sure you get we're doing 5s and 10s. So we'll do see, I'm grabbing all that skin 4 or 5 times. And then we do a nice long stretch that she likes.
Yeah, they do
And
like
she
this.
relaxes her hand.
They'll even put their arm up, please. Please, give me a good stretch. So it's very well tolerated by the animals. And this movie is published as part of this paper if you want to look at it again.
4. Oh, that feels good. 5. Eek.
So this was less than 10 minutes a day, and that included just calming the animal down first because Jeff wasn't always here to do that for us, so we had other people doing it. And this initial study, the other rats in the study also just got light handling versus the manual therapy treatment for daily for the 12-week duration. And the animals handled it very well. We looked for a variety of things. And they seemed to do well with it. And what we found was success, that the percent of successful reaches increased as the weeks progressed, And the successful reaches is defined here as did they reach over or did they reach under the maximum and minimum expected grasp force? This one's like perfect here. When they reach like between these two green lines, they get a food reward. And so they do have some sort of like criteria that they have to reach, right time frame, and then within these force criteria. And they got better. For the grip strength, this is the training effect. It's a pretty negative training effect. The same thing occurs often with mechanical allodynia. That high force in that last week is the moment that the tissues start to have some injuries of small to larger proportions. And yet the manual therapy shown in black here improved them. They had improved grip strength over the initial training compared to the control task animals. We also look for spontaneous pain behaviors. They're defined here as instead of reaching with the whole lever bar, they're reaching with like 1 or 2 fingers, or they're using both hands, supinated, pronated. They do anything they can to get that food reward. And so you can see what we're looking at here, but we're also the guarding and the fumbling are key points of like discomfort, and that you also see in humans who have developed a pretty strong repetitive injury. And if you look at the controls, you can see there's a guarding across the whole point. But if you look at the treated animals, there's no gray. So the guarding seems to be prevented, and the fumbling, which is not often, it was here in week 4, is also absent from the treated group. When we look at the tissues for that collagen, because this was the fibrotic container hypothesis, someone said, do the animals alternate forelimbs to prevent fatigue or injury? Do they predominantly use one forelimb over the other? It's a very good question. They alter. It does depend on the animals. I think that some animals, we get groups and they're like all sisters, because we do female rats, and they're all sisters and they're all left-handed, and then the next one's all right-handed. But there's some that always come in bilateral. But over time, they often will just switch and do whichever limb is easiest for them, as you can see here, which is easy for them to get that food reward. So the switching becomes more often as the weeks go on. But in the treated animals, they are able to remain with their preferred limb more. So great question. Thank you. Now we're trying to think about that fibrotic container hypothesis as our mechanism here. And you can see here's in the control, there's a lot of collagen shown here in blue, because this is a Mason trichrome stain where collagen is in blue. In the connective tissue around the lumbricals and the median nerve of the forepaw, and around the median nerve at the level of the wrist, that is decreased in the task animals. So here's less blue around the nerve and the lumbrical here, and then at the wrist as the median nerve is going through it. And if you look at a higher power, you can see that this collagen is even intraneural between individual fascicles, not just extraneural, which would then enhance the problems of nerve excursion and conduction velocity. And we quantified that, and we did see that the manual therapy did reduce this, suggesting it is breaking it apart. And we see similar changes in the dermal tissues. Remember, there are a lot of nerves going through the dermal tissues here, and the manual therapy is reduce that denseness of the dermal and subdermal tissues. In muscle, the collagen 1 is shown in red through here, and you can see there's less in the treated animals. TGF beta also was a bit less. It's not huge there. It's not maybe the best test for this, or they didn't develop quite as much. And then you can see some injury spots in the flexor muscles themselves, shown here by a lot of collagen all at one point, which we could not find in the muscles of the treated animals. We did an ELISA on serum in the animals because the TGF-beta is also released into the serum, and we did see an increase in serum TGF-beta in these animals, in the untreated task animals, as opposed to the treated. Looking at the tissue, we can see more of the TGF-beta using a different immunohistochemical method. And you can see there's a lot of fibroblast and fibroblastic cells that are expressing TGF-beta in the untreated animals and the dermis of the connective tissues, and then some spots in lumbricals, which was decreased in the connective tissues of the treated animals. And that's really interesting, the TGF-beta, because TGF-beta is a key inducer of fibroblast proliferation and matrix production. So, summary one, this manual therapy seemed to work. It reduced the collagen around the nerves and dermis and in the muscles. It certainly prevented the development of some of the sensorimotor declines and improved the reaching and grasping success and the grip strength. Reduced levels of the transforming growth factor beta, both in serum and in the tissues, which is great because that's a strong reducer of collagen. So is the fibrotic container hypothesis supported? Well, you get one result, you think it's a mistake, so you keep trying to see if you can repeat it. So we went on to repeat it because in past studies, I've seen that there's a huge inflammation-induced fibrosis component to my repetitive strain injury model, and into humans as well with these disorders, that the repetitive strain injury, the musculoskeletal disorders, create an inflammatory reaction, which itself can drive fibrosis, and then each of these drive the functional declines separately, not just together. So we thought maybe we should look for that too. We didn't look for inflammatory reactions in the first study, and we should look to see if it's either inflammation and or fibrosis associated with these various sensory motor declines. So we repeated it, but this time shorter, 3 weeks, so that we could see what's going on in the middle. We look for conduction velocity changes, tissue changes. We changed the model manual therapy, in this case, to just the bilateral gentle forearm mobilization, and the forearm skin rolling, which is the myofascial release, and then the long stretching, to see if like a superficial, or what we were defining at that time as the superficial treatment, would be effective and the changes that we were seeing in these tissues. And then the results were compared to, again, untreated task animals and controls. And in the behavior, we look for performance in operant task, and you can see by 3 weeks that the number of reaches is increased in the treated animals. Compared to the untreated task animals. So that's exciting. The reach impulse, which is the amount of force on the lever bar and the milliseconds that it's holding it, increased. And there's the minimum for food reward, but you can see the treated animals look much better. And then this is the percent of successful reaches, which is increased as well. This is very early, so they're still learning the task, but you can see we had increases. If we look at sensory motor behaviors in general, we can see reflexive grip strength was improved in the treated animals, which is the gray square, compared to the untreated task animals, which is the black round one, almost to control levels. Here's the training effect right after training. Then the treatment starts. You can see it's improving. In this case, this is related to the question asked by Bill Reed earlier. These animals maintain their non-preferred reach limb, and you can see that even in the non-preferred reach limb, there's like some increase, although it's nothing significant. The 4-paw mechanical sensitivity, it's week 3. You can see that here's the controls. That's the normal response to these various size monofilaments. And the task animals are showing mild four-paw mechanical sensitivity, but that has disappeared in the treated animals. Excellent. And then we're always looking for spontaneous alterations because we feel like that's our most strong outcome. And you can see that in the treated animals in pale gray, that the limb switching decreased by 3 weeks again compared to the untreated task animals. The pulling with the various digits is lower, and then the guarding is gone again by the 3-week time period. So what about the tissues? Well, we see a lot of neural ongoing activity. So there's this increase, and this was done with Jeff Bove in an open nerve assay where he's doing fine nerve fiber assays, and you can look for ongoing activity. And the ongoing activity looks like this. So these are recordings from neurons that you see here in the task animals, and they're exhibiting a mechanical sensitivity during wrist extension or just ongoing discharge as you are just have the electrode impaled into the nerve. And all of this did alter the conduction velocity in a different way than exposed. Right now and then before, now at the short term, you're seeing a lot of ongoing aberrant activity. Again, the collagen is decreased in the task animals, which you see over here. But the focus here was to also look at inflammatory cells. And you can see that the untreated task animals have a lot of activated macrophages. They're CD68 positive in the nerve, as well as degraded myelin within the nerve. And these were improved with the treatment. So perhaps then the treatment is helping to move the inflammatory cells along, improve fluid flow and enhance sort of like the healing properties in some way where the inflammatory cells are lower in number. So if we look back at this model, you can see that this 3-week study, you had a decrease in the inflammation and a decrease in the fibrosis. Presumably a decrease then in the inflammation-induced injury because we didn't see the ongoing activity in the nerve itself or the degraded myelin. And then the functional declines were improved. Now, this was short-term, though. What if we go long-term? At long-term, one sees that inflammatory macrophages like the CD68, which secrete a lot of inflammatory cytokines, differentiate into M2 macrophages that are low in CD68 but high in a CD206. So that's an M2 type macrophage that are also seen to produce TGF-beta and other groups. If these are around on long term, that can contribute itself into chronic disease or injury because the M2 macrophages can not only prolong the inflammation and stay here, but prolong the TGF-beta production, which enhances the collagen and then the fibrosis. So we did that same study, but long-term, but altered it better. This was like a beautiful design where we had controls treated upper extremity or lower extremity. And then the task animals where you treat the injured limb, the upper extremity, or you treat the alternate limb, which is not injured, the lower extremity, just to like fake them out. So you're like testing the placebo effect, essentially, in all of these animals. And then we call them treatment if it was upper extremity or an active control if it's a lower extremity. Again, we did just these types of manual therapy, what we would call superficial manual therapy. But we did look to see if there is superficial. And this test with this palpometer, which is a force transducer on you can see on the finger itself here. This is Jeff's finger in an X-ray machine. He put silver fingernail polish on a glove here so you could see it easily in the X-ray machine. I wouldn't advise you doing this, but Jeff's brave. And you could see that even our superficial task Our superficial treatments went pretty deep. The force of skin rolling is pretty high compared to like the mobilization and the stretch and glide. So especially compared to what we call deep strokes, are the wrist AP glide, which we did in the initial studies. So we're really doing like a moderate to deep therapy for each of these animals. And that's what our first part of this study is the pulpometer to assay the applied force. And what we saw was the inflammation again. Here's our active control task animals. We see an increase in CD68, an increase in nerve and muscle and tendon. You can see it all here in the epitenon, as well as the increase in the CD206, which is the M2 type macrophages in those same tissues. And that's decreased in the task animals, not quite as far as the controls, but you can see that when we quantify this, there is a decrease over time in the task animals that were treated. That's the task TX, in each and every case, a little bit less in the muscle here of the CD206. But after this 12-week treatment, we're reducing the inflammation from M1 macrophages, as well as some, at least for the nerve, and less in the muscle of the M2 macrophages. And here you can see in tendon, it's reduced. We do inflammatory cytokine assays, and we can see various, here I've summarized it here. Cytokines are increased the most in the untreated or the active control treated task animals, and it's lowered in the treated, look, that's supposed to be treated, sorry. The treated animals, that's supposed to be TX, except for IL-10, which is great to see, because IL-10 is an anti-inflammatory cytokine. So one mechanism might be that the treatment is increasing IL-10, which is helping drive down some of these inflammatory cytokine reactions. Again, the collagen around the nerve has decreased with the treatment. And the collagen in the muscle, which you can see is green here, is decreased in the treated animals. And we could even see that with a gel electrophoresis and immunoblotting method. And then these are ELISAs down here, which we can see that the collagen is decreased, but not TGF-beta. TGF-beta remain increased. And is that because they're active? Remember, these animals are active, they're still active, and even just moving, the lever bar can often increase TGF-beta production in muscles. In terms of behavior, the animals improved. They were the pulse, so this is a temperature, a cold temperature sensitivity, was decreased with treatment. Grip strength improved with treatment, and then fewer the animals set in the corner. So this was was reiterated in a longer study that prevention was helpful. But what about reversal? So what if the animals work 12 weeks and then take a rest break for 6 weeks with or without treatment? Will that work? And in here, in this one, we go back to the original design and do all the components of the manual therapy that we showed in the very first treatments, like every component, presumably superficial and deep, now that we know they're all there. And what do we see? So we're hoping for a reversal after all the time of this repetitive injury problem. Start with behavior. Well, here is our probing with a 1 gram monofilament. This first one is task, which is just here at the 12-week. And then the other two are rest. So it's task plus rest, or task rest plus manual therapy. And you can see in the task plus rest, there's an increased hypersensitivity. That's partially improved with the treatment, but rest was a treatment as well. And rest plus or minus manual therapy were similar. So the rest, the cessation of the task, was a huge component of their improvement. Same thing with percent change in grip strength. Rest was as effective as without manual therapy as with. So there wasn't any improvement. Grip strength is improved, but rest as well as rest with manual therapy from task levels. The noxious temperature, the same, the animals avoided 12 degrees with task and then avoided it less after the rest period. And same thing with a 4-paw sticker removal, where you put an Avery sticker on their forehead to see how they can like use their wet limb. Are they willing to use it? And you can see that the task animals really hate this and they don't want to like reach up there. So they just don't. So they fail the test essentially, while the rest animals have improvement, but the manual therapy improved that the most. So this one showed the most improvement, that entire limb movement, likely due to the stretch and all of everything together. We did a Nicolette tape nerve conduction velocity, which is done in vivo, and to look at the median nerve conduction velocity. This is the same one as you use in humans. This is how I do it versus the free nerve ending that Jeff is doing. Not saying anything wrong about his, it's just a different method. And one can see that this is the control nerve conduction velocity. Task is down. The rest with or without manual therapy improves it. So it's really driven by rest. Collagen, same thing. Oh, and somebody asked about the running wheel. Oh, that would be fabulous. And I think that that's what I would suggest at the end, that they need more. Bill, that they need more than just manual therapy. They need to do something more. And I have other studies where animals even doing partial task have a better recovery than animals doing nothing. The rest itself is not the best plan. They need to do something in addition to rest. And we'll come back to that in just a minute. You'll see that the myelin is, the tissues looked improved. Except for some of the extraneural fibrosis here. The tissues look improved, but I think it's just not enough. Because if we look at TNF alpha, the rest is driving the muscle, TNF alpha, the rest break itself, the collagen. The big feature, though, of manual therapy is to increase IL-10. So again, we see an increase in IL-10 in this second study, which is going to help drive down inflammatory changes in the tissues. When I compare everything together, which I'll show, let me show the design. What if I compare everything? Prevention versus reversal. The first groups where I did prevention, the second groups where we had the rest with it. If I compare that, which is better? Well, the manual therapy did improve, and the rest did improve the cross-sectional diameter of the muscle. So continuing do the task, the muscle, the inflammatory problems in the tissues are sort of preventing some of the muscle repair. The rest improve muscle repair. And so you have some improvement here, although the manual therapy is pretty good itself and just increasing that from there. It's hard to say. It's not the best test. The most clear point was the IL-10, and then the serum TNF alpha, rest, cessation of the injury moment, the task, is the improving factor. And if I go back to this and just throw one more point in, Bill, to talk about what this is all about, is what about bone? All of this chronic inflammatory drive that we see in the serum, like the TNF alpha I just showed you in task animals that are untreated, also has a broad sort of effect. It talks to the blood-brain barrier. We've done tissues studies on that, where you have a lot of central sensitization occurring because of that cytokine storm. But the cytokine storm is also affecting bone. The bone in the widespread, but particularly in the upper extremity, is undergoing an osteopenia. This is bone volume. It's decreased. Oops. Bone volume is decreased in task animals with no rest and no treatment. It's increased most in the task plus manual therapy, and I think it's because you're actually not with the rest, but you're doing a task and a manual therapy at the same time because you're reducing the inflammation and still allowing loading to occur. And so the loading is how you build bone. And if you have less inflammation and then the loading, the osteoblasts rule the day and bone grows. If osteoclasts rule the day, the bone disappears, which is what you have here, because they're the osteoclasts are the sisters of macrophages, and they're phagocytic and eat the bone. So if you look at like bone mineral density down here, you can see the bone mineral density is also quite low in the task animals. But in fact, only the task plus manual therapy improved the bone mineral density back towards control levels. The rest was not appropriate, which is why exercise might work. But the manual therapy is adding one more loading, although it's very brief. It's like less than 10 minutes a day. An exercise routine would likely be better. And if you look at the cortical tissue mineral density, nothing seemed to rescue it other than like being a control animal. But I'm hopeful over here that we could come up with something that would help rescue the bone osteopenia that's developing in these animals with this constant inflammatory drive, the task, and the cytokine storm. So in summary, I just want to give a few moments of time to everybody. The treatment was performed a short period of time. Usually it was, at the beginning, it was 5 days a week, and then it went to 3 days a week. The 5 days a week did the best in the bone growth and reducing some of the inflammatory problems. In the reversal, rest seemed to be as effective as just the rest plus manual therapy, except for IL-10. The IL-10, which is an anti-inflammatory cytokine, was increased with manual therapy with or without rest. So pros. Prevention is great. Like it seemed like at every point we had a lot of prevention, but it didn't really improve all the bone radial osteopenia as much as I had hoped. Because I think it's too short of a time period, 10 minutes a day, 3 days a week. The reversal, you have some improvement here and there, but rest was just as good. I think that if we look down here, the rest improved things. And the rest with manual therapy only partially improved the fibrosis and did not improve bone osteopenia. So I think that the rest itself was not a great treatment. With or without manual therapy, more is needed. Or perhaps 6 weeks is not enough time. Or certainly, I think 10 minutes a day is not enough time, is another intervention needed. And of course, then, if we want to talk about prevention, I'm sure insurance will not cover us all having a manual therapy treatment every day on our way to work or after work, although I think that would be great personally. But so quickly, I have a lot of people to thank through the years for a lot of this, including the bioengineers who helped like develop the machinery in the first place. And here's a bunch of pictures of people in the lab. I need to update this. I think Parth is on here. Parth is an MD PhD student in the lab right now using another treatment model, CB2, for our repetitive strain injury model, and it appears to be working quite well. So it's an ECB2 agonist for the pain. So I'm going to stop the sharing. I would love people to weigh in. Oh, thank you, Ellen. So I really believe and I would like to write this up sort of like as a review, but have people weigh in. If people are interested, you can email me or Victoria or Lara, Ellen Lumpkin. I think it would be nice to like address like prevention versus reversal, different things that might be useful or better for actually improving the outcome. The idea of exercise would be great, for example. So here's one. Do I have any plans of knowing anybody looking to run a similar study in humans, maybe in apprentices in the trade? If that would be great. I don't know of anyone, but it would be wonderful. Also, do you think if any administered manual intervention could be effective, like foam rolling, self-stretching? I do. That last point would address where I think the less than 10 minutes a day, 3 days a week is too little, and sometimes too little too late. Um, and that that more is needed, whether it's exercise or more self-administration of something at home. When I've gone to physical therapy, they give me, tasks I'm supposed to do at home, including the rubber band things, which I think would be quite beneficial. Hi, Fran.
Mary, I just think I'd like to wade in here. I left a comment earlier on that there's like an elephant in the room with manual therapy because you're touching, and there's this little nerve fiber in the skin that loves to be stroked and regulates a whole load of stress responses purely by touch alone. So how can you disambiguate the contribution of CLTMRs away from your manual therapy, or are they supportive of each other?
So the touch itself was shown in the animals where we had all the active controls.
Right.
So in the designs, where in our last designs where we had control animals receiving treatment of upper or lower extremity, as well as task animals receiving the same treatment but to the uninjured limb, and they're not cognitive enough to know the difference, I think. Then that addressed that point, that the placebo effect of the touch itself. So the touch itself made no difference in the animals. It had to be the combination of the touch, the treatment, plus an injury. Like an injury somehow has driven a physiological change in the tissue where the manual therapy is affecting either by the fibrotic container or increasing the IL-10 and decreasing, therefore, a lot of the inflammatory responses.
Okay, I think this is heroic work, by the way. It's years of work going into that. It's tremendous stuff. Thank you.
Hi, Bill.
Mary, my question over there, you think passive, does it have, I mean, it's manual therapy is passive with there, whereas running wheel's active. And so do you think if you had a device where the animal just had the arm going through like a stepper, you know what I'm saying, where the arm is just, or maybe flexing, I guess maybe a forearm, maybe more flat, or something with forearm motion, do you think you have to have the components of manual therapy, or is it just movement?
It's interesting that you say that. I've had this discussion with people at NIOSH when I developed this. Part of the injury is the awkward position of reaching like this. This is not a natural position for us or the rats to do this for 30 minutes a day. So this would be like a person, a worker who's using a hand tool like this a lot, and their whole arm is being affected. When we look at the tissues, we've looked all the way up to their trapezius. It's also involved. They do have a trapezius myalgia. And doing the he didn't publish it, but a researcher in NIOSH did it where he had the animals have, instead of a full like this, the lever bar was close to the portal, and they just did like this. And he did not see the changes that I see. So the extension is the awkward position. And I'm sure that the exercise wheel would be helpful, but I don't know how to actually emulate that actually. But in some studies that I have going on with Laura Stone right now, we have exercise wheels. And in the repetitive injury models, we've published two, the second one's coming out, where a voluntary running wheel is lowering inflammation in and of itself. So they work, run, and that did improve them dramatically in terms of lowering the inflammation, even though it was discontinuous, lowering the inflammation and giving them some more movement.
Right. Yeah. Circulation, increasing circulation, movement, contraction. I think all those are kind of key components. Yeah. Okay.
And then if one were to redo this, I'm not funded to redo this, but if one were to redo this, the running wheel might improve a lot of the tissues, have more muscle growth, improve the osteopenia. And then the manual therapy could be used to decrease the focal points of inflammatory changes, injury, or collagen buildup, is what I'm thinking. Yes, Laura.
Thank you very much for your amazing lecture. I'm Shuhei. I'm an orthopedic surgeon and a postdoc in Laura's lab. And manual therapy involves multiple components. And regarding the mechanism by which MAT works, which is a key factor, neural gliding from stretching or like mechanotherapy, mechanical stimulation of the MMT, which is a better.
It's interesting in this model, but also in a lot of workers with this whole problem, which includes Amazon delivery people and Amazon packers. That's the delivery systems right now of our Amazon are the people or the workers who have the most problems that match this, like right now. And the people have asked me, why not just do carpal tunnel release in the animals? Well, and the nerve gliding. Well, the answer is it's everywhere. It's in tendons and muscles, not just it's in forepaw, forearm. I've done studies where I've looked all the way up to the trapezius. In a surgery, where would I start? How could I possibly pick out that much collagen? So my belief with the manual therapy is that it's going to reduce that widespread sort of collagen buildup, just like exercise and manual therapy. With the manual therapy could be used for focal problems. Exercise would be a more whole body exercise, while the nerve gliding and then the nerve surgery would be too discrete. You're only treating one tissue out of all of them. The bone will also not respond to the nerve gliding problem. I did talk to some neurosurgeons about this for years, and Peter Ramadio was the one I know the most. He's retired now, and he does carpal tunnel surgery release. And he said so many patients come back, patients with this problem, and they come back and they go, I still am not better. And the reason is they only treated one problem. What about the patients with the epicondylitis? The epicondylitis would not be solved with this. And then Bill's talking about the meat packing. Oh, the butchers, the meat packing, and the people who do the chicken like dissections so we can have our boneless chicken breast, our boneless like thighs. They have terrible repetitive strain injury from this force and a sharp movement like this at the same time. And they not only experience carpal tunnel frequently, as noted in the chat, but also a lot of epicondylitis. And I've gone to the NIOSH meetings where they have people from the chicken processing plants in, like the leaders, the people who run them, and they just consider those butchers, people you just like move on in a few years. In other words, throwaway workers. They come in, they get their injury, you let them go. I'm pretty horrified by this personally. And so I don't buy boneless thighs. It's a consequence because I can't think about it. But to think about it, it would be great for those people in particular to have something, anything. And I'm not saying that nerve glide studies aren't important. It just can't be the only treatment. Combination treatments are going to have to be used for success, I think.
Thank you.
Have there been any efforts to try to kind of rotate workers between several similar types of movements? Because a 6-week break, I was gonna say, can you help us all advocate for 6-week vacations? But
Yeah,
realistically, we
rotation.
can't all take 6-week vacations, especially not multiple times a year. But kind of rotating activities.
Yes, workers who have job rotations do better. Not the ones who change their time. The shift workers, that sucks because sleep disturbance is a contributor. So I have a publication out on sleep disturbance. Another one's just coming. Laura and I have more coming. The sleep disturbance itself is enhancing the inflammation. So not shift change, but job rotation is good because as long as you're trained well. The reason why I say that is some of the workers who have been at the job the longest have the least repetitive motion injury because they've learned the strategy. So what worked is to have the older people with the strategy hook up with the younger people who just came into the job without the strategy so that they learn the tricks of the trade of how to relax in between. Don't go home and do a lot of knitting. Apparently knitting is like a comorbidity at home. If you do a lot of knitting and you do a lot of like slicing all day long at work, you have to reduce your comorbidities, for example. Yeah.
Thank you. Well, thank you so much. We are after 9 a.m., so I think we'll wrap it up there.
Okay.
That was
Well, thank you
excellent.
and if you're interested in, anybody interested in like trying to put this together and expand it into um, a review, please email me.
Gonna put your email in the chat, Mary?
Yes. Let me use the correct mouse here. Sorry. I'm in 2 computers at once.
Yeah.
And of course, Halima and Ellen and Laura know my emails as well. I just feel like there's a lot more to go with this and what ideas could be utilized to improve and and like combined for improved outcome for the patient. So weird to see me twice. Well, thank you.
Thank you so much. I'll stay on a moment so everyone can copy the email, but can sign off now.
Thank you.
All right, have a good one.